This is a 65-year-old female presents to the emergency department with complaints of chest pain, palpitation, and dizziness. So I have to determine if this patient is stable or unstable, right? Because it could be chest pain that happened last week. It could be palpitations that happen every 2 days. It's not a big deal. So we need to determine that first. So there's obviously fever. They have tachycardia. It's irregular, and the pulse pressure is 127/77. Okay, so far there's nothing that tells me this is like an unstable patient, right? So this is very stable to me. So I'm gonna go ahead and click OK. This is a 65-year-old female presents to the emergency department with complaints of chest pain, palpitations, and dizziness. The patient reports that she has had episodes like this on and off for the last 4 days. So this has been happening on and off. Again, not acute, not unstable. We can treat her in an outpatient setting, actually. These episodes will last between 20 minutes to 2 hours, where she will have chest tightness, shortness of breath, dizziness, and chest pain. It seems like an arrhythmia the patient has. Now, she says that she will have to lay down, which helps a little bit. So the patient became concerned when her symptoms would not go away and sought medical attention. She does not report that she has been more stressed recently. She does report that she has been more stressed recently, worrying about his children who are having financial difficulties. So I'm building the social diagnosis. This could be an arrhythmia. Also, she said she's worried about everything. So that could be generalized anxiety disorder. And she's been diagnosed with generalized anxiety disorder. She's never been hospitalized. She currently takes alprazolam and no drug allergies. She has not had any recent vaccinations. So as soon as they say this, you have to give the vaccinations that we talked about earlier, right? So yeah, this is a female patient, pap smear, Tdap. She's young. She's actually 65. So pap smear and Tdap are things I would give this patient. So where do we leave this? So the social history: the patient is married. She has 2 kids. Blah blah. She has an occasional drink with friends. Now again, every time they mention alcohol, you have to come up with alcohol. So we have to talk to her about alcohol, even if it's occasional drinks. This is your job as a doctor. She denies any tobacco or marijuana use. She denies any illicit drug use. That's great. So the patient's a teacher. She enjoys reading a book. So everything here is okay. So I wanted to go take a step back and talk a little about arrhythmias before we go forward. And that's going to help us build a little of understanding of what tests to order and how to deal with any arrhythmia that comes in the exam. So let me stop sharing. And let me try to open the whiteboard. So whiteboard. Okay, so let's scroll down a little bit. All right, so scrolling here, let's talk a little about tachycardia. So tachycardia, so a tachycardia is basically a rhythm greater than 100. Now, keep in mind that most patients can get compensatory tachycardia, and compensatory tachycardia can be for a lot of things. The most common reasons are fever and also dehydration. So before you start the whole workup for tachycardia, make sure the patient is not compensatory. And usually compensatory tachycardia is always less than 150. So if it's more than 150, it's probably pathologic tachycardia. So more than 150 is your worrisome tachycardia, and you have to deal with this. And this could be a serious arrhythmia. So the way we classify these are using 2 things. The first thing is this patient stable or unstable, right? So if the patient is, so let's go here. If the patient is unstable, or if the patient is stable, the patient unstable again, chest pain, altered mental status, acute heart failure, severe chest pain. These are things that are unstable. If the patient is unstable, you have to shock them. So there's 2 types of shock that we have. The first, the synchronized, so sync cardioversion, and the other one is defibrillation. Quickly, the difference between them is synchronized cardioversion. You put in the vest, it syncs with the QRS. It drops the shock at the, so if you go here, P, QRS. So it drops the shock at the peak of the R. Whereas defibrillation drops it randomly. So this is random shock. So now, any person that presents with arrhythmia, that's tachyarrhythmia, you would shock them synchronized cardioversion, except for two things. The first thing is VFib. Obviously, you want to defibrillate VFib. The second thing is pulseless VTAC. So VTAC, or also polymorphic VTAC. We'll talk a little bit about those in a second. But anyone that comes in with arrhythmia, tachyarrhythmia, synchronized cardioversion. If it's stable, you want to treat them obviously based on two things. So if this is a stable patient, like a patient we have right now, you have to look at the QRS. QRS is usually 0.12 seconds, milliseconds. If it's a short QRS, so narrow QRS, so it could be narrow. Narrow QRS is called narrow QRS tachycardia. Or if it's wide, so greater than 0.12, wide QRS. If it's narrow QRS, we're talking about three things. It's supraventricular, basically. So it's going to be AFib, A flutter, and it could be SVT or P SVT, so paroxysmal supraventricular tachycardia. If it's wide QRS, it's basically VTAC. And VTAC has two types, monomorphic, and here also polymorphic. The monomorphic, AFib, A-flutter, SVT, they all get synchronized cardioversion, except polymorphic VTAC gets defibrillation, and ventricular fibrillation also gets defibrillation. So let's talk a little about how to manage these patients. So this is where our patient is going to be today. So if the patient has PSVT, which is paroxysmal supraventricular tachycardia, they get these structured systems. The pulse is going to be regular. It's not going to be irregular. It's going to be regular, but it's going to be tachycardia that comes. It's more than 150, comes every once in a while. In that case, just look at the name, PSVT. Please start vagal treatment. So first step is always vagal treatment. So vagal maneuvers. Doesn't work, you have to give, so if you're adenosine. So if the patient has AFib or A-flutter, we go down here. The way we treat them is called race. Remember, your heart is racing. So rate is, R is rate or rhythm control. So in this case, you're thinking mostly about controlling the rate. The patient's heart is beating too fast, so beta blocker or calcium channel blocker. Rhythm control, you're thinking mostly about giving an antiarrhythmic. So mudorone usually works. And also you can give flecainide. So any antiarrhythmic works. Procainamide, all these things. So A is anticoagulate. Anticoagulate. So for anticoagulation, real quick, we think about the CHADS-FAST score. So CHADS-FAST score. So this is CHF, hypertension. So this score helps us determine who should get anticoagulation with AFib. A is for age greater than 75. D is diabetes. S is our stroke patient. So if a patient has stroke, vascular disease. A is age greater than equal to 65, but less than 75. And S is sex category, so and female basically. So go a little bit here. So if the score of 0, obviously you don't, no coagulation. Score of 1, you coagulate only in a male patient. And score of 2, you coagulate in everybody, including females. The reason why we coagulate in someone, so yeah, you can use the half-lead, but The CHOTS-FAST score is the most commonly used and it's so easy to remember. But you can use the hot split as long as it works for you. So 0, 1, 2. The reason why we take 2 for females is because you get only one point if you're a female anyway, so you need another point. So if a patient has score greater than 1, if they're male, start anticoagulation. The anticoagulation of choice for us is going to be warfarin. Remember, every time we start warfarin for a patient in the CCS case, or even in real life, you have to get the PT, PTT. So we'll do that later. So once we have that, C is cardioversion. Cardioversion. Only if the patient is unstable or if they fail treatment with RNA, right? And E is etiology. So now that we have an understanding of how all of this works, zoom out a little bit here. So let's go back actually to the case. So I'm going to go back. So I think I have to share my screen. And okay, here we go. Perfect. All right, so now we're back to the screen again. And we're thinking this patient has obviously tachycardia, it's tachyarrhythmia. So the first thing we do, we already, we did the physical exam. We only read the beginning of the case. So I'm gonna go ahead and stabilize this patient. When I say stabilizing, we don't really have to stabilize them like they're sick, but I would want to start IV access while I get the vital signs and stuff like that. So vital signs, and you want to have your cardiac monitor. You want to have your IV access. I'm not giving them anything. I'm just giving these 3 things just to be ready. So here every 1 minute. And you can actually do the physical exam and go back and put these orders because it's not an emergency case, so it doesn't really make a difference. So IV access here. So I'm going to go ahead and start the physical examination. So we're going to go with physical appearance, skin, so why don't we take a step back? So let me go here. Actually, stop sharing. A little bit about the causes of AFib, because it's going to help us kind of get to the differential diagnosis. So I'm going to start the whiteboard. There's a really nice mnemonic that I used to use for AFib, and it's called PIRATE. So remember, a PIRATE picks over your SI node and the heart starts racing. So these are the 2 mnemonics that you would use for these patients. So let me zoom in here. So PIRATE is PIRATES, and that's going to help us find out the etiology of your AFib. So the first cause is pulmonary, and the idea here, anything that causes arterial dilatation of the atrium, causes AFib because it irritates the SA nodes. So you have your PE, so the patient has pulmonary embolism, or they have COPD, or they have obstructive sleep apnea, all that stuff. Iatrogenic is also a very common cause when we can't find anything. R is rheumatic heart disease. So remember that rheumatic heart disease can cause mitral regurgitation, MR, and MR can cause dilatation of the atrium, and then AFib. A, and this is the most common cause, atherosclerosis. Atherosclerosis. So it could be an MI, it could be a very, anything that has to do with the heart, with coronary arteries, could cause AFib. Thyroid. So thyroid. So thyrotoxicosis is a cause of AFib. And E is endocarditis. So endocarditis. And S is 2 things. So it could be sleep apnea. And sleep apnea causes pulmonary hypertension. Pulmonary hypertension increases the pressures in the right atrium, and that causes atrial dilatation. It could also be sick sinus syndrome. So sick sinus syndrome. Now, this is going to help us with ordering our test, right? So you need a chest X-ray here. X-ray chest. For rheumatic heart disease, you want to get your echo to rule it out. For atherosclerosis, you want to make sure you have your ECG, troponin, right, to rule out an MI. So an MI is a very common cause of AFib. Thyroid, you're gonna get your TCH, right? Endocarditis, your echo again. Sleep apnea, 6-sinus syndrome. You would want to get your chest X-ray. You want to get your BMP. All these things can help you rule out electrolyte problems and things wrong with the heart and for 6-sinus syndrome. So these are the things we're going to order for this patient. So let's go back and share our screen. All right, so for physical examination, we want to focus on a whole bunch of things. So physical appearance, we want to go with the skin. I'm going to go ahead and HANT, chest, lung, heart. Every time someone has chest pain, you have to examine the abdomen because the abdomen could be a very common cause of chest pain. So I'll go ahead and examine the abdomen. And you don't need to examine genitalia or rectum. Extremities of the spine, not really, but neuro it's like maybe because the patient has dizziness, they fall, syncope, neuro is warranted. So click OK. So now we're going to find the back again. The cardiac monitor, which is a cheat code because it's going to tell you if the patient they already told you that the patient has AFib. So you already know what it is before getting the ECG actually. So irregular tachycardia, it's AFib. Remember the algorithm we talked about. If it's unstable, shock them, synchronized cardioversion. If they are stable, then you want to do rate, rhythm control, anticoagulate if their SHAT score is more than 2. If they're female, in this case, she's a female. So general appearance well developed, well nourished, mild apparent distress, no nodules, no other lesions. Head and neck examination is normal. Lung examination is normal. Heart examination, irregular rhythm. Okay. Abdominal examination is also normal. Neuro examination is normal. I'm gonna click OK. So let's go to the orders, right? So for the orders, always start with what? CBC, BMP, LFT, and TCH. And this gives us a lot of the things that actually cause, AFib. So now let's talk a little bit about our pirates, right? Pirates. Atherosclerosis, what do we order? ECG, troponin, right? Rule out endocarditis. Let's get an echo, right? So now that we have echo, we can also get a chest X-ray to rule out pulmonary causes. We can start thinking, now that we've ordered basically everything we can order for this patient. Now let's think a little about treatment of how to treat this patient. So patient is stable, AFib, rate, rhythm control, right? So for rate, what we use to control for rate is beta blockers or calcium channel blockers. We're going to go with beta blockers, so metoprolol. Calcium channel blockers, they don't have to prescribe it if I already did beta blockers, so one of the two. So now let's talk about rhythm control. Rhythm control, you can give amiodarone. You don't have to give amiodarone to any patient. This is actually controversial, but just for the sake of getting the point, give any antiarrhythmic to control the rhythm, and that's it. So amiodarone, beta blocker. Now we have to think about our, SHAT score for anticoagulation. This patient is a female. She has hypertension, right? So I'm going to go ahead and prescribe anticoagulant, and for that I'm going to go with warfarin. And anytime we start someone on warfarin, I have to get PT, PTT. Check their INR, make sure that they're good and they're not going to bleed on us, right? So once I have all these things in here, now keep in mind the patient could deteriorate at any time. So we have to admit this patient, make sure they're good, and admit them in the ward. Make sure once the arrhythmia has subsided, then we can send them home. But we have to change the location in a bit to inpatient. So CBC, I'm going to order only once. BMP only once. LFT once. TCH, so it's going to be TCH for serum. 12 lead ECG. Troponin serum. Cardiography. Again, don't get a transesophageal cardiography because that's very invasive. So transtracheal does the job. So if you can't find it here, you can just put echocardiography. X-ray of the chest. Got to put that. So go here to rule out any pulmonary causes. And metoprolol to control their rate. I'm going to give it IV. Amiodarone to control their rhythm. Give it oral. Warfarin to anticoagulate them. PTT, TT, so make sure that they're not bleeding. So once we have all these things, I'm going to change the location. They're in the ED and they have arrhythmia. We can't keep them in the ED. Just admit the patient. So admit them as an inpatient. Confirm the move. Every time you admit a patient, When I think about diet, NPO, and bed rest. These are the things I want the patient to stick to until we figure out what's going on. Let me stabilize them. So NPO. So click OK. Now let's obtain the results. So I'm going to go ahead and advance the clock 2 hours. The ECG came back, showed atrial fib with rapid ventricular response. So continue, we already treated it. CBC came back, so it's negative. BNP is negative. All the electrolytes are good. Troponins are negative, so ruling out atherosclerosis. So remember RACE, rhythm, rate control, A, anticoagulate, C, cardioversion, E, etiology. We're trying to find the etiology so we can treat it. Now, obviously, this may not be in this case because it's a very short case, but echocardiography came back normal. So no endocarditis, no rheumatic heart disease. X-ray came back normal. No pulmonary causes. Continue. LFTs came back normal. PTT is normal. Good. Patient updates. The patient reports that she is feeling better. That's good. Now the patient's feeling better, right? So, okay. Continue. Another patient update. The patient feels much better and no longer has chest pain, palpitations, or dizziness. I'm going to click stop here. So the case is ending. We actually ended the case because we did everything we can for this patient. So what do we talk about? This patient drinks alcohol a little bit, so we have to give them alcohol abstinence. So alcohol, give them the alcohol talk. So alcohol abstinence. Patient has not taken her vaccinations, right? So because she didn't tell us when the last vaccination was, I'm going to go ahead and give them Tdap them, and make sure you give them a pap smear because she's a female. And that's it. So now we have all these. Alcohol abstinence. You can talk to them about medication compliance as well, so you can add that if you want. We actually did not order a cardiac consult, so I'm going to do 2 things here. The first thing I'm going to add is medication compliance. Remember, you can always add these consults at the end because sometimes you forget them. Cardiology consult. So medication compliance. Boom. Consult. Boom. Here. Put atrial fibrillation. Yeah, that's basically it for the case. Covered everything that has to do with AFib. Do you all have any questions?
Where was the location? Where did we change the location to?
Yeah, so the patient was in the ED, and that's where they presented, but we changed it to the inpatient ward. They're going to be admitted until we stabilize them, until they feel good, and then once they're done, we can send them home basically.
So we don't stabilize them in the emergency department?
We did. Remember, we ordered the IV access. We ordered all the drugs that we have. We ordered metoprolol, amiodarone, warfarin, all of that before we actually transfer them. So that's in the ED, but they can't remain in the ED forever, right? Think about it. We have to keep them somewhere, and they have to be monitored. So it's going to be the inpatient part after you order the initial orders.
Okay.
Now, let's say a patient comes in with sepsis. This is going to be an next case. You have to, from the beginning, before you order anything, you have to transfer them to the ICU. Otherwise, they might deteriorate in the ED, and you would lose them, right?
Okay.
So, yeah.
Thank you.
Okay. Any other questions?
So Mariam is asking, do we do a heparin bridge? Has split. I don't know what is has split.
For these cases, not really, and for the exam, doesn't really matter. So as long as you anticoagulate them, and remember, warfarin, you can give also the direct factor VIII inhibitors, so dabigatran, enoxaparin, all these things. So if you just prescribe a single anticoagulant agent, it works, and you get the point. And that's it.
Doctor, I also have a question. So in this case, the patient was stable. He was a case of atrial fibrillation, but he was stable according to the vital sign. And after we did complete physical examination, then we go to order sheet, order all of the stabilizing in addition to differential diagnosis order. And then without moving the clock, we just simply change the location of the patient. In this case, right?
Yes, correct. Yeah.
Okay, my question is if we have a case of arrhythmia but it's unstable, the difference is we go to the stabilizing order first and then focus physical examination, and then we come back and before we move the location, we need to order a stabilizing order. This part is important. So imagine that the patient has, any unstable sign, and before we change the location of the patient, we just need to move the clock after we order metoprolol or DC shock or whatever, right?
Yes, but so let's walk through this. If the patient came with, let's say, chest pain, they have hypotension, and they're very unstable, right? So this is the first thing you do is you stabilize them. So order all the vital signs, both oxygen, and make sure you have your IV fluids, IV access, all that stuff, right? Now, this is called the ALS algorithm. So like acute life support, you get this course when you start residency. But basically what you do is you check for ABCs, and we do that already with the stabilization, but then you have to give them, cardioversion because they're unstable, right? So instead of prescribing metoprolol and warfarin and all that stuff, you'll first, give them cardiovert them, and then order the rest of the test, and then you'll move on. Now, a very important note I haven't talked about, actually reminded me, is that, in this case, if the patient is stable, do not order cardioversion. And this is the step 3 question, is that you need to wait at least 3 weeks before you order cardioversion, because the patient, because they have AFib, they're hypercoagulable. They could have an embolus in the left atrium. So if you cardiovert them, the embolus can actually move, go to the brain. The patient can get an embolic stroke. So do not do cardioversion for at least 3 weeks until anticoagulation has been stabilized in the patient, and then you order cardioversion. Unless the patient is unstable, the first thing you do before you order any of the CBC, BNP, LFT, TSH, all that stuff, is to do the cardioversion.
So, Dr. Abbas, imagine that the patient is in shock or chest pain, shortness of breath, or blood pressure less than 90. Before we go to focus physical examination, accompanied with a stabilizing order, we are going to intubate the patient, right?
No, you don't intubate the patient in this case if they're breathing, right? So if the patient is breathing, you don't intubate them.
Right. Just DC cardioversion accompanied with IV access and all of the stabilizing order, right?
Correct. Yes, correct. Yeah.
And then focus physical examination, and then we can change the location of the patient at this time.
Yeah, I mean, if they're unstable, directly to the ICU. So like inpatient or ICU doesn't really matter for the exam, but if it's an unstable AFib patient, you give them to the ICU. The ICU would take care of them because they could go into cardiac arrest at any time, or ventricular fibrillation, and you want to make sure they have an eye on them. So ICU works great for these patients.
Yeah, thank you. Unfortunately, we didn't have any unstable arrhythmia in the emergency cases to go through, but thank you so much.
Yeah, of course. So again, we don't have to do the heparin bridge here for this purpose of the exam. So just give them warfarin, and that would work great. And you'll get the full point.
What did you mention? You just said.
Yeah, there was a question in the chat box. Do we do heparin bridge for these patients? So in the real exam, you don't have to do heparin bridge. You can just start them with warfarin or a direct factor 8 inhibitor that doesn't actually require heparin bridging, and that would work great for this patient.
Yeah. As you said, Dr. Abbas, the heparin bridge was only necessary if it was a valvular AF. So in that case, the only medication accepted was warfarin. And yeah, we had to go through this warfarin, PT, PTT, INR, and the DUAC was not acceptable. But in this case, as you said, DUAC is acceptable. If we had chosen Eliquis, we didn't have to go through PT, PTT, INR, and it was totally acceptable.